Hi everyone, Jessie here. I'm a registered dietitian and I help people with irritable bowel syndrome. Today we are very lucky to have Dr. Amy Burkhart join us. Dr. Amy Burkhart is the only two of integrative medicine doctor who are also registered dietitian. So she is very familiar with diet. Let me see if I can invite her. And today we are going to talk about celiac disease. So Dr. Amy Burkhart is the celiac MD. Let me see. Well, I don't think I can invite her. Let me see if she's joined me here. Hi everyone, thank you so much for joining us. We are going to, inviting Dr. Amy Burkhart, the celiac MD, to join. I might have to do this again because she's not able to jump on. Okay, hi everyone, I'm so sorry. I don't think, let me start again. I'm gonna message her real quick. Oh, she's here, hi. Okay, let me get her to join. Hi everyone, thank you so much for waiting. Technical difficulties as always. We are waiting for Dr. Amy Burkhart to join. Let me click it one more time. Oh, joined. Hi, Dr. Burkhart.
There we go.
How are you?
Sorry. I'm good. How are you? Sorry, there must have been a delay.
No worries. We're just glad you are here. So today we're going to talk all about celiac disease. And celiac disease is a condition that you have to test out of in order to get an IBS diagnosis. However, testing for celiac is complicated and a lot of nuances. And we're also going to talk about non-celiac wheat sensitivity as well. So to begin, how about we talk about what is celiac and what is non-celiac wheat sensitivity? And Dr. Amy Burkhart here. I just did a quick introduction about you. You're an integrative medicine doctor as well as a registered dietitian who also live with celiac disease. So you know the ins and outs of the diagnosis of celiac disease, the diet impact when it comes to celiac and non-celiac wheat sensitivity, and of course, you know, a patient advocate for anyone with chronic conditions.
Sure. Well, thank you for having me, Jessie. Sure. So first, we'll talk about what celiac disease is, just briefly, and then how you determine. And then we'll later talk about how to determine the diagnosis of it. So it's an autoimmune condition. It's lifelong. It can come up at any time. You can get diagnosed as a child. You can get diagnosed as an adult. The body basically reacts to gluten in an abnormal fashion. So it creates an autoimmune response to the protein in wheat. And when that happens through the immune system, it attacks different parts of your body. People think that it's only in the digestive system, but it really can, we consider it kind of a multi-system disease. So it really can affect the brain, the skin, the digestive tract, the heart, everything, indirectly the bones, etc. So it's a multi-system disease. The only treatment for celiac disease at this time is a strict lifelong gluten-free diet. There are no medications. There are a lot being studied, and those of us with it and that work with patients that have celiac disease hope that some of those pan out so that patients will have options. But for now, it's just it's a strict gluten-free diet. And so non-celiac wheat sensitivity is kind of an umbrella term. And what it means is basically someone eats gluten and they react, they get sick. They could get migraines, they could get rashes, they could get stomach pain. They could look exactly like a celiac patient as far as symptoms, but they don't have that same autoimmune response. It's a different type of immune response in the body. So the only way that we have at this point to diagnose it is to make sure someone doesn't have celiac disease through testing while they're eating gluten, which is a super important point. And once they go through proper testing for celiac disease, then, and if they don't have it, then we can say, okay, you don't have celiac disease. We know you still get sick from gluten. Here's the possibilities. It probably isn't one particular thing. A lot of people with non-celiac wheat sensitivity, and we can just call it kind of gluten intolerance, just because otherwise it's a very long term, is that a lot of them actually have FODMAP intolerance. That's a large portion of them. Some of them are reacting to other components of the wheat other than the FODMAP component, like something called an ATI protein. And then also, we think there's also other proteins in the wheat that certain subpopulations are reacting to that we just don't know. Unfortunately, there's no test for non-celiac wheat sensitivity. So it really is what we call a diagnosis of exclusion. You don't have celiac. We know you get sick from gluten. We believe you. That's the other thing. We believe you that you don't feel good from gluten. And, but we're not quite sure why. And then there's kind of an algorithm of things that you do for that population as well.
Right, definitely. Okay, well, let's talk about testing for celiac and why it is so difficult. So there's serology tests and also biopsy. I'll let you take over.
Okay. Yeah. So just to kind of re-emphasize, so the most important thing for testing is that you're eating gluten when you're testing, and you have to be eating enough gluten, and we can talk about that later. So we're going to assume when I start talk about this first part for testing that somebody is eating gluten. So if you're eating gluten, there are screening tests, and I don't know if you want me to go through the names of the screening tests because it's kind of hard for people to remember sometimes, but
yeah,
there are screening tests for people, and I will tell you there's a kind of a difference depending on institution and practitioner as to what screening labs are done. But there is a fairly general consensus that one called a TTG and a total serum IgA should be involved initially. Beyond that, there are a couple other tests that people use, 3 others specifically, depending on institution, depends on how those testing protocols occur. Mm-hmm. So, the people that I see people that are kind of a little more complicated, I think, than most people. They're not just like, hey, can you just screen me for celiac disease? There's a lot more layers to things. So I will tend to do a more thorough evaluation. Mm-hmm. But I think that in the general population, if you're just trying to do a general screening for celiac disease, they will often do something called a TTG and a total serum IgA. And then it gets a little more complicated beyond that, because if someone has a low total serum IgA, then that kind of defaults to another cascade of tests. Mm-hmm. But again, if they're not eating gluten, those tests mean nothing, because you have to be eating gluten for those tests to be accurate. There is another test called a genetic test. That genetic test can be very, very useful. It isn't affected by people whether or not they're eating gluten. Which is helpful because there's a lot of people who just go on a gluten-free diet with no testing. And so what do we do with that population? So the genetic test is helpful kind of in that situation where about 40, there are 2 genes that we know of currently that are associated with celiac disease. You only need to have one of those 2 genes to be susceptible to celiac. Actually, you only have to have half of one of them because one of them has 2 parts. So you don't have to have both genes to have it. If you have one of those markers for celiac, that however does not mean that you have celiac disease. It just means you're susceptible, because 40% of people walking around have one of those 2 genes. But only somewhere around 3% of them actually have celiac disease, 1 to 3%. So just because you have a genetic marker does not mean you have celiac disease. However, where it's helpful is if you don't have one of those markers, celiac's off the table. So that's where it's helpful. And so it can be very helpful in people who are on a gluten-free diet, and then we do the genetic test and it's negative. Then we can say, okay, celiac's off the table. Let's figure out what else is going on. Okay.
Okay, yes. And thank you for clearing up the myth that you don't need to have both sets of the genes to have celiac, because that's something I hear all the time that doctors tell their patients, whereas you just need half of one set of the gene, then you are at higher risk.
Yes.
Another question for you regarding genetic testing.
Mm-hmm.
Is there any genetic tests on the market that consumers can purchase themselves? Because not all doctors will order the genetic tests, and sometimes they are more expensive. Is there anything you would advise?
Yes, and I'm going to blank on the name.
Is it 23andMe?
No, not 23andMe. I think it's Gluten Detect. I'm totally blanking. Let me look really quick while we're talking. I don't want to.
Okay.
Yes. I had it.
So for anyone who is joining us now, we're talking about testing for celiac. And now testing for celiac, Dr. Burkhart was saying you have to be eating gluten prior to testing, and you have to be eating enough gluten. And enough gluten meaning 2 slices of bread every day if you're in the US for 6 to 8 weeks. If you are outside of the US, in Europe or in Canada, I believe it is 4 slices of bread. So it's a little bit different. Let
me clarify the gluten challenge part. You and I talked the other day, and then I kind of looked a little deeper into it because it's a little different. Respectfully disagree. So there's a lot of controversy on what a gluten challenge means. There's actually a paper that came out 5 days ago, believe it or not, that's a meta-analysis on gluten challenges and what they mean. And there is no consensus on exactly what it means. So I reached out to my friend yesterday at the Beth Israel Harvard Celiac Center and said, what do you guys use? So they sent me their kind of protocol for their gluten challenge. It's different than the paper. So I'm just kind of emphasizing there is kind of a general consensus on, I would say, 2 to 4 slices of bread, anywhere from 6 weeks to 3 months.
Okay.
And sometimes the problem with that sometimes is then you run into, if people can't tolerate other things in the bread, is that what's creating the symptoms? So there is also an alternative protocol for using just gluten, just vital wheat gluten. Mm-hmm. And that would be by teaspoons. And so you start at a lower amount and you go up to a higher amount. The same with a regular gluten challenge. You don't start at 2 to 4 slices completely. You start at a lower dose and kind of titrate up, because some people will get very sick. And then you have to factor in, is this worth it? Can they tolerate this? How long can they do it? And then what do we do at the end? Do we do a blood test or do we biopsy them? So I would say right now the water is very muddy about what a gluten challenge is. I agree with you in that 2 to 4 slices somewhere for 6 weeks to 3 months is kind of what people do. But I would also say that it's on a case-by-case basis. And you have to look at, because there are certain patients in my population for sure that I would never do a gluten challenge on, because they would end up immediately in the hospital. So sometimes you're just making your best guess, I guess. Does that make sense?
Yes.
Okay.
Yes. But for anyone who is on here, if you are doing the testing, eat your gluten.
Yes. Make sure, otherwise the testing doesn't mean anything. Yeah.
Yes, and that's the difficult thing with celiac. Yes, and you were looking up the genetic markers. The reason why we brought this up is
it's Gluten Detect. So there is a company called Gluten Detect. They're based out of Irvine. They have a wonderful pathologist who is very invested in providing this service to the general public. I think you can, I'm not sure about this part, but I'm not sure if you can get help with interpretation of the results once you see them, because they can be a little confusing sometimes reading them. So I think they provide that service too, that you could get consultation. But because it's a genetic test, it's just a cheek swab.
Okay.
Right. So
I've been recommending people to do 23andMe because I think they do the subset of the DQ2 and DQ8 too, but you are not familiar with it.
Yeah, so I use Gluten Detect because I know they're very invested with the celiac community. Yeah. Well, I mean, I haven't used them much. I've just spoken to them a couple times. 23andMe, when they first started doing celiac testing, it wasn't complete. I think now it is. And so it's just a bigger company. It's just easier, like as far as like from a patient's perspective, like trying to get help if they need it, gluten detection.
Right.
Yeah.
Okay. Oh, that's really good to know, because yeah, with 23andMe, I don't think they offer any consults. And with these kind of cases, it's best to.
I hope I'm not speaking incorrectly, but I think they do. I think they do. Yeah.
Right. Right. Okay. Well, thank you for talking about. So we talked about serology tests, genetic tests, and also the next thing would be biopsy, because there are a lot of nuances when it comes to biopsy. Do you want to talk a little bit about that? So we have, with biopsy, that comes with endoscopy. And then ideally, the gastroenterologist doing the biopsy, doing the endoscopy will take out some biopsy. But I'm going to let Dr. Burkhart here talk about the detail and why it can be a little bit tricky at times.
Sure. So an endoscopy is just the procedure that is a confirmatory test for celiac disease. So if you have a positive blood test for celiac disease, we then do a confirmatory test with an endoscopy where they put a tube down your throat and then they take samples of your intestine. Not big pieces, just tiny. You don't feel it. You're asleep. It's very quick. It can also be done in the case where even if the blood tests are normal, if the suspicion is very high based on family history or symptoms, they might also do an endoscopy then, or for rechecking symptoms. So that's the endoscopy. People think that the endoscopy is it is considered the gold standard for the diagnosis of celiac disease. And you and I were talking the other day about how I think that's kind of ironic, because it also is not perfect and there's a lot of room for error. What happens sometimes is if people do an endoscopy, often the gastroenterologist doing it, if they don't see a lot of celiac or they're not that familiar with what the kind of ACOG, the Gastroenterology Society guidelines are, it's that you want 4 to 6 samples and you want them from specific parts of the intestine. So there's something called a bulb. They need a couple 1 to 2 samples from there and the other 4 from the other part of the small intestine. So sometimes, and unfortunately, far too often, not enough samples are taken. And because celiac disease is very patchy, you really need more samples to try and find it, right? Because it's kind of like shooting in the dark a little bit, because you can't always visually see it when you go in there with a scope. And so the more samples they take, the better the chances are of you finding it with a disease that's kind of patchy. The other problems is sometimes it only shows up in the part called the bulb, and people don't do that, and then they forget that part, and then you're missing a certain amount of people with celiac disease. And then there's room for error on the slides and the mounting and the tissue samples, and so there is a lot of room for error on the biopsy itself. So a lot of people will that work with celiac patients will also look at the labs, the whole clinical picture. If the biopsy comes back normal or indeterminate, there's a couple things you can do. You can you can have it reread. You can send it to a celiac center, like at University of Chicago, Stanford, Columbia, Harvard, and have it reread. You would have to do that through your physician and have them talk to the center, because sometimes it's a matter of a specialist who's very familiar with these slides looking at them, saying either I agree with you, I can't see, or this was not done, it's not mounted properly, I can't see this, or we don't have enough samples, you need to do more before they even review it. And then it's, a discussion between the doctor and the patient as far as like, do you rebiopsy someone? Do you just use the rest of the clinical data that you have? It depends on a case-by-case basis. So it's a little bit ironic that it's the gold standard, because there still is a lot of room for human error, I guess. So,
yeah. And that, well, what we've just talked about basically concludes why celiac disease is so hard to diagnose and why it takes so long for a diagnosis to happen. And oftentimes patients are suffering on their own for the longest time, for I think last time I checked is 10 years is the average time for people to get a diagnosis.
It's somewhere between 9 and 10 years to get a diagnosis. And I think it's getting a little bit better because there's more awareness, and the testing is better and easier. And more readily available. It's less expensive, but we have a long way to go. Only about 18% of people with celiac disease are diagnosed. That leaves a lot of people that are walking around with celiac disease that don't know they have it. So 1/8, that's how the percentage that are diagnosed out of 100%. It's pretty low.
Yeah, that's unfortunate, but hopefully we will have better technology and better diagnostic tools in the future. Okay. So we talked about how to rule out celiac so far, doing all the right tests and then this genetic test. If you don't have any set of the genes or part of the genes, then we can most likely rule out celiac. Is that correct?
If you don't have any of the genes, yes.
Or half of a gene.
Or half of a gene, right. If you have no genetic marker for celiac disease, celiac's off the table.
Right. And then that brings us to, if you are still reacting to gluten, then that brings us to non-celiac gluten sensitivity or gluten intolerance in short. Right.
So for gluten intolerance, it's a little bit trickier because celiac, we have a like if it's diagnosed, we have a pathway to follow on what to do. Gluten intolerance is a little bit more of a Pandora's box in that it could be, as we mentioned, a FODMAP intolerance. It could be another protein intolerance, or it could be something we don't even know, or it could be a wheat allergy as well, which we haven't talked about, or an actual allergy to wheat, which people think, well, if I don't have a rash or I'm not having trouble breathing, that's what people think of as an allergy to a food, right? Like peanuts, right? We're all familiar. I kind of always try to use peanut allergies as a comparison. But you can have just vomiting, stomach pains. Those can be a wheat allergy. So that's a little bit separate from gluten intolerance or gluten sensitivity, but we haven't talked about that. And so that's kind of a third category I just want to kind of briefly mention. It's not as common. But so then we have gluten intolerance where, okay, you don't have celiac, you don't have a wheat allergy, but you eat gluten and you get sick. So what do we do? There's, depending, again, it's very individual as far as how people approach this. I'd be curious how you approach it, but as an IBS dietitian, because a lot of people will just start with a low FODMAP diet and then go from there. And if the low FODMAP diet doesn't work, then you start searching. Because I have the luxury of having an MD behind my name, then I may do the low FODMAP first. I typically, to be honest with you, will do labs first and make sure there's nothing kind of organic going on in conjunction with a very extensive history that might clue me towards something. Because if in that history I find there's no FODMAP intolerance by history, we start looking elsewhere. So I personally don't start always with a low FODMAP diet, but a lot of people do. And so you can do it that way as well. I don't think there's kind of a general consensus on how to start. And I also think it depends on what tools you have in your toolbox, right? As a dietitian, it's not easy to get labs. But for me, I have like I said, the luxury of being able to order labs and making sure there's not some nutrient deficiency or other malabsorption thing or, something else going on.
Yeah. For those people who are curious, we start with looking at patients' labs and past history, family history too, because a lot of these is genetic with celiac and non-celiac wheat sensitivity. If there is a strong family history, and then perhaps, and sometimes we start with low FODMAP, but for people who have strong family history or medical history, we may start directly with a strict gluten-free diet because that may be most helpful. If we can get more labs from their physicians, with their GI, working alongside their GI, I think that would always be helpful, especially for patients who are not fully gluten-free yet, but depending on when they did their celiac testing, what the results were, that would be, it's a more of a case-by-case thing that we do. But with non-celiac wheat sensitivity, what we normally do is help patient get on a strict gluten-free diet, and then we do a gluten reintroduction with sourdough bread. And the reason why we use sourdough bread is because that teases out the FODMAP piece and also ATI. That is a protein that some people may be intolerant to. But of course, there can still be other components from wheats that people may not tolerate. And if people react to sourdough bread, then that's when we think, okay, this is potentially non-celiac wheat sensitivity. And then we guide the clients or the patients accordingly from that, and then determine the intolerance level, because some people are, oh, do you want to talk about the spectrum of intolerance when it comes to gluten intolerance? Because it's a huge spectrum.
It is a huge spectrum. And I think people always, the big question always is how much gluten, this is not celiac. We're not talking about celiac at all. Because the answer for them is no gluten at all, even a tiny amount. But for the people that are not celiac and are eating gluten and getting sick, it's a huge spectrum of what that tolerance level is. So there's definitely, I have plenty of people who are just as sensitive as someone with celiac disease and have to live like a celiac, whether or not their tests are negative. And then I have people who tell me they can go have pizza once a week and have no problem. And so we don't really understand why. I think part of it is because we don't really know exactly what non-celiac wheat sensitivity is. I think because we think it's this umbrella term for multiple different things. And so it's a bit of trial and error with, I think often it makes sense to kind of really do a really strict gluten-free diet initially, and then start reintroducing small amounts and see, okay, what can you tolerate? Because really the goal is to have them be as flexible as they can. I mean, it's a heck of a lot easier to follow a gluten-free diet that doesn't have to worry about if you can use a shared cutting board or a shared fryer or a shared pan. It's a heck of a lot easier to do that than it is to have to worry about those other factors that make it very difficult in multiple social situations. So I think it's good to do a strict gluten-free diet and then start adding small amounts back in and finding what I call their sweet spot of like, okay, what can you get away with without having symptoms, right?
Right, definitely. It's very individualized, and definitely something I would recommend everybody to work with a dietitian who is familiar with both gluten-free and low FODMAP. Otherwise, it's extremely challenging.
Right.
I think we've had some questions here. Let's go into Q&A.
Okay.
Somebody was saying, someone was saying, if I ate that much bread, I'll never be off the toilet. I think we were talking about the gluten challenge earlier. So someone said, I tested negative when I would already cut out gluten because no one told me I needed it in my diet. Is there any way to be tested without going back to it? Yeah.
The answer is I wish. Not at this point, because I agree with the first person who commented. Most of my patients would never do a gluten challenge. And in the 12 or 13 years I've been practicing, I have had one person complete it. And most of the time, because they get so sick, I don't even recommend it. We can't get away with even beginning to do it. And so, so the question of, is there any other option? People are looking, they're trying, they're looking at, are there kind of different markers, not the ones that are currently available? Are there different markers that we can do either a shorter gluten challenge, like 24 hours, or no gluten challenge at all? But they aren't available. They're kind of still in the lab.
Yeah. That's great. But this genetic testing can help rule out celiac.
Correct.
If someone is looking to rule out celiac.
Correct.
For now, but we won't know if it's celiac or not, if it's positive. There is someone who said, what can we take to help celiac reactions?
That's a good question. So a bit of a disclaimer before I answer this, because there's not a lot of scientific data behind what I'm about to say. So there are some basics, kind of things like your mom told you when you were little: drink lots of water, stay hydrated, rest because your body's fighting an immune reaction, Tylenol. Zofran is a prescription medication that often I prescribe for my patients just to keep on hand, because that helps with nausea, it helps with migraines, it helps with that general ick feeling. And so I often will give them a prescription just to hold of Zofran. And then there are supplements I use as well. I use fiber, to be honest with you, just psyllium fiber, because it absorbs kind of cytotoxins. I use bentonite clay or charcoal. I'm not a fan of Pepto-Bismol just because I don't like dyes and colors and things, but charcoal is basically the same as Pepto-Bismol, without all the coloring, and you can get it over the counter. Sometimes I will use, and again, disclaimer, no science behind this, but not harmful, probiotics. I will use, and I have specific ones, but probably too detailed for this conversation. And then sometimes I will use other supplements because I do integrated medicine, like milk thistle, which helps the liver kind of process and detoxify. Sometimes we use digestive enzymes temporarily because then it helps with the digestive process. And heating pads for stomach, for joint pains. Acupuncture sometimes helps people. I think that's probably a good list to start with. I'm trying to think of what else I have in my toolbox. Yeah.
What I normally recommend for people with gluten intolerance, so I don't see a whole lot of celiac, but for gluten intolerance, we recommend having a over-the-counter laxative if you are someone who is more on the constipated side of things when it comes to gluten intolerance, because that gets gluten out of your system faster. I recommend peppermint oil capsule because that is researched to help with relaxing your gut muscles, especially for those people who have a lot of spasms and pain, and just helps in general, relaxes the muscle. Peppermint tea or ginger tea. And then of course, like you said, the medications that can help ease some of the symptoms or prevent the symptoms if your doctor recommends them.
Right. Okay. And I would just off that for if you
but
do have celiac, I would not recommend those except for the ginger tea, because the laxative could probably throw some of the population over the edge, and the peppermint tea can cause reflux, which is often a common symptom. So for constipation prone, gluten sensitivity, gluten intolerance, yes. Celiac, no, I wouldn't do those.
Okay, good to know. Good to know. Yes. Okay. We'll chat one last question. How do we go about traveling with celiac? I think that could be a helpful question. It's a tricky one.
It is tricky, but it's important. And I think I will honestly say traveling is my favorite thing to do in the world. And so I say that because I think a lot of times when people get diagnosed with celiac disease, it is devastating if they like to travel because it's a little bit harder. But it can be done. It requires more planning. There are apps available to help you with restaurant choices. I have a directory on my website. It's free. It has a list of worldwide dedicated gluten-free restaurants. So even if you don't speak the language, you don't have to worry about asking questions. There are restaurant cards available in multiple languages for people to go into different countries to help them. I do recommend you always have backup food with you so that if you're somewhere where there are not gluten-free options available, that you have things in your suitcase so that you have food. And I also recommend, if you can, getting condos or Airbnbs instead of hotels because you've got a kitchen. And most of all, just don't let it keep you from traveling, because with the proper planning and making some modifications and making sure you always have backup food, you'll be okay. You'll be okay, and it shouldn't keep you from living your life. Yeah.
Right. It's having backup food, as in packing a lot of snacks that you know you can eat, and probably something higher in protein too, just because you don't know what options you will have.
And sometimes backpacking food, to be honest with you, that's non-perishable, or peanut butter and crackers, things that are non-perishable that you can keep in a suitcase. You know, there's a lot of dehydrated food, and while it doesn't sound palatable when you're starving, it's nice to have something. So dried cereals.
Right.
Yeah.
Right. Okay. Well, one last question. What is the best country to travel with gluten-free? You might know this.
Okay. I would probably say, if you asked most people, they would say Italy. Ironically, because they just have a lot of celiac awareness. I would say we also traveled in Spain. It was quite easy. South America, a little more difficult. There's not, I am bilingual and I do speak Spanish, but even then it was difficult because there's just not awareness. What other countries? Canada's good, Ireland's good, UK is good. The Nordic countries, Sweden, Netherlands, Finland, those are probably the top, off the top of my head, I would say those are the best. Yeah.
Yeah, I would say most Western European countries are pretty good if they are, especially if they are among the EU membership, because EU do have some strict, some better gluten-free protocols that restaurants and food manufacturing companies have to follow. So those could be good. Asian countries are not good because we don't have awareness. It's terrible. I feel so sorry.
I know.
And yes, but all right. I think that concludes our interview today. Thank you so much, Amy, Dr. Amy Burkhart. And if you guys are interested to learning more from Dr. Amy Burkhart, you can go to her website, theceliacmd.com. Or if you're someone with IBS and not sure what to do next, we do have a self-paced program that is led by dietitians. It's called IBS Freedom. And you can learn more about that in my link in bio. All right, everybody, thank you so much for joining us. And thank you so much, Dr. Burkhart, for your time.
Absolutely. Okay, bye, Jessie. Have a great day.
Bye, you too.
Bye.